Hello and welcome back to the first NDARC weekly webinar of 2026. My name is Bianca Varney and I'm today's chair. Today we're going to start off this year's series by hearing from NDARC's own Scientia Professor Louisa Degenhardt and Dr. Thomas Santo Jr. Professor Degenhardt is an epidemiologist and NHMRC Senior Principal Research Fellow and Deputy Director at NDARC. Her work focuses on the health and social impacts of illicit drug use, including large cohort and data linkage studies on opioid dependence, mental health, and incarceration. She has contributed to global burden of disease estimates and international guidelines, and her research informs policy and practice to reduce drug-related harms in community and criminal justice settings. Dr. Santo is a postdoctoral research fellow at NDARC, whose research focuses on drug dependence, comorbid mental health and trauma, and criminal justice involvement. He uses observational data, including large-scale linked health and justice datasets, to examine post-release health and social outcomes and to evaluate access to and impact of interventions for drug dependence in prison and community settings. His recent work includes a global review of access to services for bloodborne viruses, opioid dependence, and needle and syringe programs in prisons. So today, Louisa and Tom will be presenting their findings from two comprehensive global systematic reviews on injecting drug use and infectious disease in prisons. We also have Professor Paul Griffiths, the Director of the National Drug Research Institute at Curtin University, joining us as a panelist this week to discuss this work. Professor Griffiths is an internationally recognized expert in alcohol and other drug research, with over 4 decades of experience in addiction epidemiology, policy, and harm reduction strategies. He has held senior scientific roles with organizations including the European Union Drug Agency and the United Nations, contributing significantly to global drug monitoring and public health policy. To make the most of our time with our panel, we'll be taking questions through the Q&A function. Please feel free to pop any questions into the Q&A box at any time, and we'll do our best to get through as many as possible. Finally, before we begin, I would like to pay my respects to the traditional custodians of the lands on which we meet today. I acknowledge that I'm joining from the lands of the Bidjigal people, and I honour their elders past and present, as well as emerging leaders. So I'm delighted to now introduce our speakers on this important topic. Louisa and Tom, would you both like to turn on your camera and mic and take us away?
Thanks very much for that introduction, Bianca, and thanks also to Paul Griffiths for coming as our panelist today, and thanks to those of you who are joining us this afternoon. So as Bianca mentioned, we will be talking today about giving you a high-level summary of 2 reviews that we have completed that have focused on injecting drug use and infectious disease among people who experience incarceration. Tom, next slide. Sorry. First, I would just, in addition to Bianca, like to acknowledge the traditional owners of the many lands that we are meeting on today, and particularly want to recognise that the over-incarceration of First Nations people is a significant issue, not just in Australia, but also globally, and continues to contribute to disparities in health for many people. So I'm going to give first a little bit of an introduction to this work, and then I'm going to present on the first review, which is the review of epidemiology, and then Tom will present on the review around interventions. But first of all, what we really wanted to acknowledge that we are very thankful for the very large number of collaborators that we worked alongside on these reviews. And to really acknowledge their tireless efforts in these reviews. It's a very large team of people that at NDARC, but also our collaborators particularly at the Kirby Institute and Bristol University and Yale University. But not just at academic institutions. We also collaborated with a large number of people from other organisations working internationally. I don't have any declarations for the past 4 years that we would like to acknowledge specifically for this project, and just want to recognise the range of funding that's supported this work. So just a brief background. As many of you will be aware, both infectious diseases and injecting drug use are elevated among people who experience incarceration, and there's multiple reasons for that. There are shared risk factors for all three of those experiences: incarceration and also injecting drug use and exposure to infectious disease. But also risk of incarceration is higher for some people because they are using drugs, and particularly around criminalisation of drug use that can lead to incarceration for some people. And also, conversely, the prison environment in itself as an exposure can increase the risk of exposure to infectious disease, and for some people, use of drugs and sometimes injection of drugs. So all of these things are interlinked. So we have previously undertaken a number of systematic reviews that have focused on the prevalence of injecting drug use in the general population, and also of HIV, hepatitis C and hepatitis B among people who inject drugs. And we've also summarised the evidence on the availability and coverage of key interventions, specifically with a focus on people who inject drugs and people who may be opioid dependent, and interventions that prevent and treat infectious diseases. Those reviews have all been focused on people in the community. What we did in this set of reviews was to undertake, using the same kind of methods and logic, a review of infectious disease and injecting drug use, and the availability of interventions to address both of those, harms related to both of those, among people who experience incarceration. So we wanted to locate information on the number and rate of people who are incarcerated, and the prevalence of those behaviours, diseases, and availability of interventions. So just want to acknowledge the large number of people again, and to go into the methods. The methods for this review and the next one are similar. We, as I mentioned, relied on the methodologies that we've used in previous reviews. It's a very busy figure on the right-hand side, but basically what it shows is that we looked in a number of areas, so denoted by the columns of searches and the stages that we went through. And we went through multiple stages of searching, checking, screening, and then extraction of information. We looked not only in the peer-reviewed literature, but also in grey literature, so reports by governments, non-government organisations, country documents, international agency documents. So we looked at a range of different websites and developed strategies to do that. We also contacted people in organisations that we thought might be working in this area or have information. And as I mentioned earlier, collaborated with a range of international organisations. So this is to give you a visual summary of the rate of incarceration, and we got these estimates from a website that's maintained by a group in the UK, and this is called the World Prison Brief, and that collates data from lots of different government agencies worldwide on the rate of incarceration. And what you can see there is our estimates of the rate, excuse me, per 100,000 people aged 15 to 64 years. Darker colours indicate higher rates. So what you can see is in particularly in American countries and some European, Eastern European countries, higher rates of incarceration, and you can see lower rates in some other countries. There are gaps in some countries not having data, but by and large, there's a lot of information recorded on that website about rates of incarceration. Next slide. And when we estimated that at regional level, what we estimated is that globally, around 11.3 million people might experience incarceration, looking at those rates globally. So that's a rate around 220 people per 100,000 people aged 15 to 64 years globally. But as you can see, if you look in the left-hand column, those rates vary a lot. So in terms of at a regional level, North America, which includes Canada and the United States, at a regional level has the highest rate globally of incarceration. You can see in the middle column, sorry, Tom, the middle column is the rate among females, and then on the right-hand side, males. And those variations that you see for people overall are similar to the variations that you see for females and males, with rates much higher among men. So this is the results of data that we pulled. So we pulled all of the estimates that we could find for a given country from studies of people who were incarcerated where there was information gained around whether or not they had ever injected drugs. This is data pulled at a country level. So these are the direct numbers that we've got. And darker colour blue equals higher prevalence of lifetime injecting. And as you can see there, Australia has among the highest prevalence of experience in injecting drugs among people who are incarcerated of all countries globally. When you turn that into estimates at a global level, and then we also estimated things at a regional level as well, and for men and for women, you can see that globally we estimate that around 12% of people who are incarcerated have injected drugs at some point in their life. And as I mentioned, as you could see in the figure, as I mentioned before, there's a lot of variation geographically. So at the top is Australasia, though, so that's Australia and New Zealand, where you've got over half of people are estimated to have ever injected drugs who are incarcerated, down to very low levels, for example, in sub-Saharan Africa, where it's about 3%. Similarly, there's a lot of variation geographically for men and for women. And in some regions, the prevalence of having ever injected drugs is actually higher among women who are incarcerated than it is in men. So, and a very clear one of those, again, being in Australasia, Australia and New Zealand, where almost 70% of women, studies estimate that almost 70% of women who are incarcerated have ever injected drugs. Compared to studies in men where it's about half. So what we've also estimated was the prevalence of active hepatitis C infection. So this is not, this is RNA positivity estimation, not people ever having been not antibody positive. And what you can see there again is there's a lot of gaps where we don't have country level data on the prevalence of hepatitis C, but you can see it varies very widely and seems to be a lot higher in Western European countries, North America, and to some extent Australia, but that's lower than you might than it might once have been, and that's we think related to the fact that more recently there's been such a scale up in treatment of hepatitis C infection. So going to the next slide, if you look here at the prevalence of current hepatitis C infection, again we estimate that around 12% of people who are incarcerated globally have active hepatitis C infection, with very substantial variation, and the highest prevalence of active hep C infection being in Eastern Europe. And similar variations among both men and women who are incarcerated. So here you can see existing data at a country level on the prevalence of HIV infection. And here so for example, you can see higher levels among countries in sub-Saharan Africa, and that reflects general population prevalence. And you can see higher prevalence also in both Latin America and North America, much lower in countries such as Australia and New Zealand, where prevalence is also very low among people who inject drugs. And then if you look at globally, we estimate around just under 4% of people who are incarcerated are living with HIV, and among the highest rates of HIV are among people who are incarcerated in Eastern Europe. Again, a lot of geographic variation, and in some regions, again, where prevalence is actually a lot higher among women than it is among men, and that's certainly the case in the studies that we were able to locate in Eastern Europe, where prevalence among women who are incarcerated is estimated at around 30% versus 15% in men who are incarcerated. I haven't presented the results for hepatitis B. They are all reported fully in the paper just for time purposes, but this is showing you again a very different picture from both hepatitis C and HIV prevalence, which is prevalence of TB. And you can see here much higher prevalence in countries in Eastern Europe, Latin America, and sub-Saharan Africa. And there's a lot of countries, particularly Western Europe and also Australia, where we don't have data on prevalence, routinely collected data. And you can see there the estimates are around 2.5% globally of people who are incarcerated have tuberculosis. So a very varied picture across the globe, across different infectious diseases, and also a very varied picture in terms of the prevalence of lifetime injecting. We estimate around 11.3 million people are incarcerated globally. Around 1 in 8 of those people have ever injected drugs, which is around, when we estimate it relative to the general population, over 50 times higher as a rate globally. And those increases in rate compared to the general population are also what we see for the infectious diseases. So for that 3.7% of people who are incarcerated living with HIV, that level is around 25 times higher than the general population. So we're seeing much higher levels at a global level, and those variations relative to the general population are also much more marked in some regions than others, and all of that is reported in detail in the paper and in the appendices of the paper. So with this substantial variation in risk, there's obvious implications that this has for different countries, and that was the intent of this paper is to really summarise existing evidence to give clear guidance around where the priorities are around infectious disease management and priorities for elimination, which gives us onto the second part of this presentation, which will be given by Tom.
Thank you, Louisa. And I just wanted to start off. So my name is Tom Santo Jr. I'm a postdoctoral research fellow at NDARC. And I also wanted to reiterate before I go into the coverage of services related to the prevalence estimates that Louisa just presented on, to thank our team at NDARC, as well as our collaborators internationally for all their contributions to both of these reviews and ongoing efforts to ensure that people who are incarcerated receive the health services that they very clearly need. From the estimates that Louisa just presented, we can see that people who are incarcerated experience HIV, hepatitis, and tuberculosis, as well as have higher rates of lifetime injecting drug use. And therefore, it's really clear that we need to ensure they receive the services that will reduce the harms related to those diseases and behaviors and experiences. So just to go into first, which services are we talking about? So you can see along the left-hand side here, we're looking at different health issues related to prison or different behaviors when it comes to injecting drug use. Louisa again presented on how high the rates of injecting drug use are compared to the general population among people who are incarcerated. And for that, we want to reduce the harms that are related to injecting drug use and shared equipment use, as well as potential for the harms related to opioid dependence, which is one of the most common health issues that we see among people who inject drugs, given that heroin is one of the most common drugs that is injected by people who inject drugs. Therefore, opioid agonist treatment, which includes methadone and buprenorphine, is an essential service that we need to ensure that people who are incarcerated are receiving, as well as access to clean injecting equipment, which are both core interventions that have been shown to reduce transmission of the diseases that we see on the left hand, or the infectious diseases that we see on the left hand side column. So HIV, Hep C, in particular, are shown to be drastically reduced through availability of clean injecting equipment, as well as access to opioid agonist treatment. Importantly, for the infectious disease services that are listed in the bottom half, we're looking to not only treat infectious disease, but also prevent it and ensure that people who are positive for HIV find out early, so early detection, early treatment, and we can therefore reduce the harms associated with infectious disease among individuals, and also the spread of infectious disease within prisons and then onto the community. So just to define what we mean by coverage of services, we have our health problems, our prevalence estimates that Louisa provided in the first half of the presentation, and we have the issue of elevated rates of infectious disease, as well as rates of injecting drug use and experiences of opioid dependence is inferred from that. The first thing that we wanted to do was kind of create a baseline, understand which countries provide the service that we're interested in at all. So do they have one or more prison in the country that is providing a needle or syringe program or opioid agonist treatment? We then wanted to look at the number of facilities, but also whether or not all facilities, is it universally available, whatever service we're looking at? So whether it be testing, treatment for HIV or antiretroviral treatment, Hep C, direct acting antivirals, and treatment and testing for Hep B and tuberculosis. We wanted to know whether or not, again, it was available in one or more prison, was it implemented at all anywhere in the country, and then whether or not it was available universally for prisons. Now, again, that it's important to note with that just because something is available in all prisons doesn't mean it's available to all people. And we wanted to know, or one of the core elements of estimating coverage and finding out whether or not a service is being provided often enough or is available enough to people who need it, is looking at the programmatic data and the number of people that are actually receiving services, as well as the number of equipment that, or the counts of equipment or tests that are occurring within a country, or within this case, within prisons within a country, and then looking at those over the number of people who are in need of a certain service. So in the case of needle and syringe programs, for example, we wanted to establish, yes or no, is it available in this country? If it is, how often or how many needles are distributed for the people who who inject drugs, and then compare that to the number of people who inject drugs that Louisa estimated in the first part within that country. And so coverage is really the numerator, so the number of, say, equipment or number of needles distributed over the number of people within the country that we estimate to be in need of that service, or in this case, people who inject drugs, and then we can get a rate or a percentage that will show us whether or not people are receiving the services that they need, and whether access is really just, a availability in one prison and to two people is very different than availability to the entire population, and access that is real and implemented and backed up by numbers through the programmatic data, as well as the facility reports and things like that we'll go into in just a moment. But we can finally look at the coverage, the rates per people who are in need of a service. So say if it's antiretroviral treatment for the number of people that we estimate have HIV in a country, and we compare that to targets established by the World Health Organization as well as the UN in trying to assess how countries are doing in providing each service, as well as regions and globally. As Louisa mentioned, I won't go too much into this, but I just wanted to emphasize during this part in describing our methods that for this coverage of services, part of our global prisons reviews, the gray literature, or the literature that comes through reports by justice departments or health departments, as well as gray literature that comes from different non-governmental organizations, often doesn't come up in the peer-reviewed literature searches. And so it's really important when conducting this type of review to look at those gray literature searches, and then also contact the organizations that may have access to unpublished data, or country-level survey responses, or verified data within a country through verified sources, to establish whether or not we can say if a country has availability of a service, and then also to collect the number of people that are receiving the service, or number of equipment, number of facilities, all the programmatic data that we talked about in the previous slides. Overall, we screened around 76,000 records, and that's including the gray literature that we searched through. And we identified and included around 745 sources within this review. So again, a large shout out to the team that worked so hard on this over the past years to go through country by country for all of these services, and establish not only availability, but see if we could collect additional data that will inform our estimates of coverage. So going to the actual data and what we found. For needle syringe programs, this was the intervention that was most rare. We found only 10 countries that had any prison NSP, and that's only 5% of the countries in the world. Of those, only 3 provided all facility coverage, and I'll note with that one of those is Luxembourg and the other is San Marino, which both have 1 prison. So in terms of all facility coverage, it's quite rare, and that's among the 10 countries we see that have availability of NSPs in prisons. What is, I think, particularly shocking about that is the number of countries that we know have needle and syringe programs in the community. So there's 92 countries in the world that have needle syringe programs available in the community, and that's a stat that we know through Dr. College Frisbee, Sam's paper on coverage of interventions for people who inject drugs in the community. And so we can see that there's a real disparity in between what people are receiving in the community and what's available to them in prison. And it's very clear that there's a large disparity there, and that the risk of using shared injection equipment and onwards to the infectious disease risk and other risks, like such as injected-related injuries that occur, are particularly prevalent in prisons given the lack of availability of clean injecting equipment. Opioid agonist treatment, in comparison, is available slightly more than needle and syringe programs. And we found that around 59 countries have availability in one or more prison. So that's implemented OAT in prisons, and that's still under 1/3 of the countries globally. For system-wide or all countries that have availability of OAT, so methadone or buprenorphine, in all of their facilities, there was only 20 that we found globally, mostly in Western Europe. And something that's particularly of concern given the estimates that Louisa provided, which found high prevalence of injecting drug use within Eastern Europe and Central Asia, is lack of adoption of opioid agonist treatment in prisons in those areas. So we can see a real high area of need, and this is globally as well, a real high area of need for methadone and buprenorphine in prisons, but a lack across regions in terms of availability. Now, just like needle and syringe programs, far more available in the community. About 1/3 of prisons about 1/3 of the countries that provide opioid agonist treatment in the community don't offer it within prisons. And so that's a major concern when it comes to forced withdrawal for people that enter custody, risk of suicide and overdose, not only when people enter prisons, but then once they leave as well, post-release, the interruption of a treatment that we know is a WHO essential medicine, or is an essential medicine for preventing mortality, preventing risk of disease transmission, and preventing even things like reincarceration. We're finding that that treatment continuity is being interrupted in a large amount of countries, and then also that the availability of specific medications is also restricted within certain countries that do have availability of OAT. So now turning to HIV services within prison, we found that this is far more available, and it was one of the more available treatments in terms of the infectious disease part of service coverage. We found that 86 countries, or about 42%, had some form of HIV testing in at least one prison, and then around the same 79 countries and 38% provided antiretroviral treatment, or ART, within prisons. And so again, just to emphasize that just because countries are offering it in at least one prison or somewhere isn't the same as system-wide coverage, and it doesn't mean access as well for all people who do have HIV across the countries that even are in the blue there that provided in one or more prison. It certainly does not mean that people who are living with HIV within that country are guaranteed or even likely to have access to ART. And similar to what we see with the estimates of injecting drug use and the availability of services in Eastern Europe and Central Asia, for Sub-Saharan Africa, in particular, we see a higher prevalence of HIV from Louisa's estimates. And then unfortunately, in terms of data availability, not a lot of information in regards to availability of HIV treatment in prisons. And so again, should emphasize as well with that just because we were not able to find data on that doesn't mean that it's not occurring. It's just on a programmatic data level or availability level, we weren't able to find information on that through our pretty comprehensive searches. So again, a significant public health concern given the elevated prevalence of HIV in prisons. And similar for hepatitis C, and even more so. So we found only 53 countries offering testing, so about a quarter of the countries in the world. And then we found 47, which is just less than a quarter, offering any DAA or direct-acting antiviral treatment. We only counted DAAs, which is one of the most, or is the most effective treatment for Hep C, and is available in approximately 27% again, or 23%, sorry, of countries in at least one or more prison globally. And then in terms of availability in all prisons, only 8% we found had availability in all prisons for Hep C treatment. HPV treatment, again, even less data. Similar to Louisa, I won't spend too much time on this slide, but in addition to treatment, vaccine coverage was quite low as well. And it's of particular concern given that in many countries, people who are incarcerated are also less likely to have had the vaccination, and depending on their age. And so it's a clear opportunity to provide something that is a very clear preventative strategy for eliminating hepatitis B, not available or not documented, at least in most prisons in the world. For tuberculosis treatment, now this was the most common intervention that we were able to find in addition to screening. So about 46% of countries in the world offered screening in any prison, and just under 40%, 81 countries offered tuberculosis treatment from what we could find through our searches. Now, this is particularly important given in many countries the overcrowding of prisons and how easily tuberculosis can spread, and then onwards into the community. Again, an opportunity for treatment and among a population that's particularly at risk of developing tuberculosis, not providing, or at least not reporting on the data, programmatic data level, the number of people who are receiving treatment, the number of people who are being screened, or different type of tests that are occurring. There's a clear lack of data there in terms of how we can measure what the actual coverage of services for all people who are incarcerated are, because all people are at risk once they enter prison, and in the community as well, depending on the country. So for overall, if we wanted to just summarize what countries have different services available in at least one prison, and can look at the different combinations of treatment that are available, we can see that there's a very clear need in many countries to have any reporting in terms of availability of treatment or testing, given that we have 168 countries with no evidence of any of the interventions that we looked at, which is a major concern. So even then, in the countries that we did find were providing one or more service, they're clearly siloed. We can see a different, past that that second bar. So the second bar shows the combination of HPV treatment, hepatitis C treatment, OAT, HIV, and tuberculosis treatment, which is encouraging that those are being provided together in that number of countries, which is largely found in Western Europe, for just over 25 countries, I believe. And then after that, we look at TB treatment as the most common intervention provided, and that's siloed on its own compared to some of the other services that we see in combination. And then when we look at the 6 core interventions for countries that have it available in all prisons, we find an even, unsurprisingly, an even higher rate of countries that don't have any of these services documented to be available in all prisons, which is a major concern and shows a systemic failure, particularly given that we had no countries that offered all of these services, even in one or more prisons. When we incorporate NSP, there were 0 countries that provided one or more of all of these services in prisons. So when we look at the global population of people who are incarcerated, we can see, again, a clear number of people that we can confirm when we're looking at those red bars that aren't receiving services that are critical for preventing and treating infectious disease globally. And so of the 11 million people, we can see that fewer than 2% of people are in countries with access to OAT, HIV treatment, Hep C, HPV, and tuberculosis. And then when we include NSPs within there, it's 0 countries providing all of the services in at least one or more prison. The blue bar there represents people that live in a country that provides the service in one or more prisons. So just to emphasize that does not mean all people have access. And then the green bars are all prisons, and that still doesn't mean that all people have access, given the lack of programmatic data that we found across all the interventions. So one of the main limitations was exactly that. We weren't really able to estimate actual coverage, combining Louisa's estimates with the programmatic data that was available, because there simply just wasn't enough to estimate within each country how well they were doing in providing service access to people who are incarcerated. So we can see that 82 countries provided data in the community from Sam College Frisbee's review on community access to services. And then only 33, which is the most common intervention, OAT, provided that data for prisons. For NSPs, only 7 countries, and that's not surprising given the number of countries that reported not having the intervention. Reasons for this vary across country, but it's particularly concerning given the high risk of each infectious disease, as well as lifetime injecting drug use among people who are incarcerated. And it's somewhat ironic given certain countries are able to look at the large number of, say, overall needles or OAT that's provided overall, but if you're looking at a smaller concentration of people within often government-run facilities, then the programmatic data just isn't there. And this just shows in Sam College Frisbee's review what they were able to do, looking at the availability of opioid agonist treatment and of needle syringe programs or needle availability in the community. They were able to document in these countries what the service coverage was, and we weren't unfortunately able to do that in this review given the lack of data. Again, so overall, extremely limited coverage of the services that prevent, treat, and reduce injecting drug use. And when we look at OAT and NSPs, which are particularly relevant to people who inject drugs, it's a major concern given the elevated risk among people who are incarcerated and within prison. And overall, a clear failure to provide services for people who are incarcerated, who are some of the most in need. And so, again, a systematic failure across the globe in terms of providing essential health services that international standards and mandates have directed that people who are incarcerated receive the same standard of care that they receive in the community, or that people in the community receive. Such as the Nelson Mandela rules, which were agreed upon in 2015. And despite that, we have such a major gap in the number of people who are actually receiving services that they very clearly need, as Louisa established within the first part of the presentation. And it's clear that prisons are in major need of a increase in not only the availability of these services, but also the an improvement in reporting of how these services are provided, so we can determine whether or not the coverage is matching the level of need that we have very clearly established through our high prevalence of injecting drug use and HIV, Hep C, and tuberculosis within the community or within prisons. Thank you, everyone. And very happy if we feel that anyone feels that we've gotten anything wrong or that we've missed data. We'll be updating these reviews certainly in the future, and Louisa and I would certainly love to chat about that. So thank you again, and I will hand it over back to Bianca.
Thank you so much, both Louisa and Tom. Clearly a huge amount of work that has gone into this and providing some really critical evidence on the incarcerated population. Can I just ask that you turn on your video, Tom? And Paul, you've done so. I'd like to invite Paul now to hear some of your reflections on this piece of work.
Thanks, Bianca. I'm going to have just a few overarching thoughts, I think, and a couple of the more substantive points that cropped up to me during the presentation. And first, congratulations, Louisa and Thomas, and all the people involved in the study. The ambition of this work is really impressive. I know from working at international level, the challenge of doing this sort of review across multiple countries. And I really think the way you've adopted both a methodologically robust, but also pragmatic approach to data collection is really important and impressive. It's a great practical achievement, simply getting the networks together. So, I'm amazed and impressed by the level of your ambition and achievement. Also, I think the findings are really important for galvanizing attention at the global level on the need to address the healthcare needs of people who use drugs within, inject drugs within custodial settings. So I think it's not only is it an impressive achievement, it's a really important one. And I don't know how you could improve your study design, so I think the approach is really robust. So in my mind, these are the best estimates available, or probably achievable. But clearly heard from you, and if you look at the data underlying a lot of it is extremely poor, and large parts of the world is simply missing. And I guess people then can get in, and there can be a critical issue about the precision of the numbers you're coming up with, especially as we're living through times of rapid change. And even in parts of the world where the data has got a bit better and is relatively strong, and I know the EU data to some extent is also actually underlining it's very weak. And I can remember looking at some of the EU data and it said prison injecting prevalence in this country went from 0 to 96%. And you just think, well, we don't know anything. So the real challenge of the underlying data that you're drawing your reports on. But I don't think that really matters to some extent, because I think the study is really convincing in its objectives and aims, and it shows that people who inject drugs exist at far higher prevalence within custodial settings than in general population, and with a few notable exceptions, overall interventions that could reduce the risk of infectious disease transition are woefully underdeveloped. And I think that's the main point, and your data clearly supports that conclusion. And policymakers love a number, and it's important to have those numbers to support a policy debate. And I think what we're giving them here is the best numbers we can do. And I think that's important for focusing attention. And when you're looking at levels of needs at this level, whether it's 45, 50 or 65, is not really important. The point is services simply are not meeting needs. And again, I think I'd applaud you for that. I believe there are a couple of areas where I think caution, particularly two areas, I think the caution is merited. And you acknowledge that in your call for additional studies in the papers. And I think really these are things that are probably inherent to these sorts of systematic estimation exercises. And I think the first one is data quality and availability issues mean, I think from these exercises, you need to be really cautious and careful about drawing conclusions or trends over time, because the data is not moving at the same speed as developments, really. So I think that's where and I have a note of caution. I've seen some problems where people have tried to do that and they've actually created false narratives. And I think that's quite important, and it's a worry because the world is changing rapidly at the moment in ways I expect that will impact both on the size of the prison population and the health needs of people within it. So, I think it's an intrinsic limitation, but it's also, I think, where your study provides the impetus for supporting further research endeavours to address those sorts of questions. And whilst I think overall these sorts of numbers are helpful about thinking about prioritisation at the country level, perhaps, I'm not sure it really provides the granularized view necessary for thinking especially about emerging needs and in some countries. So we do need, again, really to use this as an impetus to do more studies, especially in those countries where they've been lacking over a long time. And I think we also have to be really mindful when we think about the global situation that we lack data on some of the really important countries like China, where cities in China are bigger than European countries or bigger than countries across the road. And many countries' data, we know very little about what's going on, but also Russia, many African countries now growing very different demographic shapes in that data, different, and again, and some Asian countries. So the worry there that there are probably the situation, I suspect, is far worse than even this paper suggests it is if we were to have a more fuller picture of some of those areas. And also, I think we have to be mindful of what's happening in small island nations in the Pacific region, particularly at the moment, where we're seeing very rapid changes in both in terms of probably injecting prevalence, but also epidemics of viral infection. So again, I think you provide the big frame, but we need to start filling in some of this detail. The next point I make is really a depressing one, neither in terms of the conclusions made or the coverage of data available, with some exceptions. Nothing appears to have changed much in at least the last decade and possibly the last 2 decades. And that's a really depressing observation. I think many of the things you're calling for now, we would have called for 10 or 20 years ago. And it's depressing that that's the case. I think in terms of lack of data coverage, there's an old adage that doing the same sign of madness is doing the same thing repeatedly and expecting for a different result. And one of the things that depresses me is the lack of progress we've made in that terms. And I guess a question I would have is, I think we need to be thinking about other complementary information sources or methods that would allow us to comment on the countries that routinely just don't have data. So how can we use something like this as a framework for actually building in, possibly with new technologies coming up with somewhat, but be able to fill a bit in some of those gaps, maybe not quantitatively, but maybe at least qualitatively to help us actually understand a little bit more about the scale needed for those places that simply don't collect information. And we've been saying that for a long time now, and the situation hasn't got any better. And it may be that includes countries where needs are changing rapidly, and it's actually important to begin to get some feel of that. And I think when I stand back from the whole thing, I think both counts in terms of service availability and data quality available, things may actually be getting worse. So we know that a lot of the funding for studies of people who inject drugs have come through UNAIDS. UNAIDS probably won't exist in a couple of years from now. We know that Global Fund has changed a lot. We know that injecting as a policy topic is not probably given the same priority it once had. And we see with US funding, global funding, the real lack of money available now for global studies. So I think one of the things I would fear is that it may be increasingly harder to do some of this work, especially looking at injecting people who inject drugs. And the world is also, I fear, and I have good data on this, but maybe it's just, I think it's getting more repressive, and also with big demographic changes. And this means I would expect patterns, rates of incarceration are changing in ways that mean rather more than less people who use drugs may end up in custodial settings. So I think that's, again, something that we need to be thinking about. So a question I have to you both really is, do you think it will even be possible to do a study like this in 5 or 10 years' time, just the way things are going in terms of data availability? And if so, what do we need to be doing to address that? I think looking to the future and thinking about health needs of people who use drugs in custodial settings, we may also need, and this isn't a question of the paper, it's more a more question about doing more, we need to widen the lens we use. And I think in many parts of the world, injecting as a mode of administration is declining. And we see that quite dramatically in some parts of the world. And we really need to think, what does that mean for thinking about the health needs of people who use drugs in custodial settings and appropriate responses? And it may even be that issues around initiation of drug injecting within prisons, because of some of those contextual factors you've highlighted, may become a more important issue. We're also seeing that amongst populations who do inject drugs, often it's not opioids that are being injected so much anymore. So again, issues about service responses there need to be thought about. But I don't think in terms of the risk of viral infection, even that change isn't necessarily going to be any less. So I think we need to remain a focus on that. But I do think we may need to think about a wider set of health needs, increasing, for example, drug overdoses becoming an issue in a lot of custodial settings, or things like trauma, addressing trauma and issues around mental health and neurodiversity. And I've seen some studies recently looking at stimulant use, ADHD amongst young males, and offending patterns and incarceration, which is really quite startling.
I'm so sorry. I'm just going to have to jump in, Paul. We've almost run out of
Okay,
time.
so I'll
I'm
finish
so
that.
sorry.
Sorry, no, I can thank you for stopping. So great, amazing study. I think
Yes.
it really highlights the need for new research. I just congratulate the team, and I think it's stimulated me at least to think about all the things we should be doing in the future. Thank you.
Absolutely. I might jump in if you could try and answer a question in 30 seconds, Louisa and Tom, that would be amazing. We had one question on the data of DAAs not being available in all prisons in Australia. Do you have any more details on this you can share, like which states and territories are lacking, or if this is a reflection of available data?
So just to look at it from a step back, Medicare, when you go into prison, you don't receive Medicare anymore, which I'm not sure a lot of people in the community know. And so that's essentially kind of the reason for, well, it's not the only reason, certainly, but we have had to go to each state and territory individually to confirm that. And I'm not exactly sure which state or territory didn't have data available, but because they didn't have data available, we weren't able to say all prisons in Australia. And that certainly applies to a lot of countries around the world where people are receiving healthcare outside of their standard federal system for, say, even universal healthcare. So the disaggregation obscures the actual data.
Amazing. Unfortunately, I think we'll have to stop there. Thank you so much again to Louisa, Tom, and Paul, and everyone for joining. That was an incredibly interesting session. Please join us for our upcoming webinars, which you should be able to see if it's available. And lastly, we're conducting a survey of the NDARC webinar series to help us assess its impact, reach, effectiveness, and to identify opportunities for an improvement. You'll see a QR code on the screen. Also, there's a link to this survey on the NDARC webpage, homepage. We would really appreciate you taking a moment to complete the survey feedback. It takes less than 5 minutes. It's anonymous. And if you don't get the time to do it right now, please just remember it's on the NDARC homepage as well. Thank you, everyone.
Thank you.
Thank you.